Hi and welcome to Physiotutors podcast episode 57 with Sarah Michiels. Sarah is a physiotherapist, manual therapist and assistant professor in musculoskeletal rehab at Hasselt University in Belgium. Her special interest is tinnitus, and she has published many papers on the topic in the last 10 years. I'm very excited to talk to her about tinnitus and how we as physiotherapists can play a role in its management. Sarah, welcome to the podcast. It was a bit of a wait to get you on, but I'm very happy to finally talk to you.
Thank you, Kai.
Okay, Sarah, to start, could you please give us a definition of the kind of tinnitus we'll be talking about today?
Well, the kind of tinnitus we will be talking about today is somatic tinnitus. That's how it's called. And it is actually a kind of tinnitus where input from muscles or joints in the cervical spine or the temporomandibular area are either changing an existing tinnitus, and I'm going to tell you that is actually the majority of the patients, but in some rare cases, this change in efferent information from the neck can also cause a tinnitus.
Okay, so it can be a distributing factor, but it can also be the cause.
Yes, indeed. Yeah.
Okay, yeah. And moving on to my next question, which we already touched upon, is how is tinnitus related to dysfunctions in the cervical spine? Is it only the cervical spine, or can tinnitus also originate from dysfunctions in the temporomandibular area?
So in most cases, it is actually a combination between upper cervical spine problems and jaw problems that change this tinnitus percept. So most of the time, it's a combination of both.
And can you maybe explain how it works? How is that related?
Yes, indeed. So incoming information from this upper cervical spine and from the temporomandibular region actually is collected in some areas in the brainstem, and from these areas it is transmitted to, the regions we know, somatosensory cortex, but there is also a connection with some very important auditory areas in the brain. And these connections are present in all of us. We also have these connections. Because, for instance, they are used to make sure that when you're chewing, you can't hear yourself eat. So it would be very annoying if you could hear all those chewing noises. So in normal circumstances, when you're chewing, when your masticatory muscles are active, then sound is actually lowered a little bit, or perception of sound is lowered a little bit. But in some cases where patients have a tinnitus, a constant increase in tension in masticatory or cervical muscles actually does the opposite. And this change in input will cause an increase in spontaneous activity in the auditory brain regions. And that's how a tinnitus can originate, or how an existing tinnitus can get louder or can change in sound.
Yeah, that's really interesting. If I think about it and what you're talking about now, it sounds very similar to cervicogenic headaches, like where we have a mismatch between efferent input from the cervical spine or the muscle spindles, where pain is actually projected from the brain into our face sometimes, although it's coming from the neck. So it sounds a bit similar.
It is actually quite similar. The strange thing, however, is that with cervicogenic headache, you stay in the pain perception region, whereas for tinnitus percept, you switch to a completely different area in the brain, to the auditory area. So that makes it very interesting for me as well.
Yeah. And can you talk to us about prevalence? So how many people have this, or maybe how many people do have tinnitus, and how many of them do have the somatosensory type?
So if we look at the general adult population, about 10 to 15% of the general population has tinnitus. So that's quite a lot of people.
That's a lot, yeah.
And in this group, about 1 out of 4, so 25%, has a somatic tinnitus or somatosensory tinnitus.
Okay, and maybe as a side question, what are other causes of tinnitus if it's not somatosensory?
Well, in many cases, or the best known origin of tinnitus is hearing loss. So what happens there is actually quite similar to what happens when you have a limb amputated. So when you have hearing loss, you have very little input at certain frequencies of the hearing. So certain brain regions receive very little input, and that results in spontaneous activity in these brain regions just to make sure that they keep existing. So, and that spontaneous activity actually is perceived as the tinnitus sound.
Okay. And switching back to the somatosensory tinnitus, is there a certain age group or gender or other characteristics that, or is a certain group that do most often have this sort of tinnitus?
Well, for tinnitus in general, we know that the older you get, the higher the risk of getting tinnitus, and that has something to do with the hearing loss, because hearing loss is often age-related. But we know that in the group of somatic tinnitus patients, these patients are often slightly younger. So not like in their 20s, but where an average tinnitus patient is in or are in their 50s, so like 52, 53 mainly. Our somatic tinnitus populations are a little bit younger, so on average like 48, just a few years younger on average.
Yeah, and is it more prevalent in males or females?
No. So there's an equal spread in both genders.
Yeah. And if we're talking about epidemiology already, are there certain risk factors to develop it?
Well, for the somatic tinnitus specifically, of course, having some neck problems and jaw problems is a serious risk factor.
Yeah.
But for tinnitus in general, we know that hearing loss, having a job where you often hear loud noises, that's a risk factor, but also stress. So if you often are in stressy situations, that is also a high risk factor for developing tinnitus.
Makes sense. And how can we as physiotherapists diagnose tinnitus? Is there a reliable and accurate way?
Well, for tinnitus in general, I always advise to first send the patient to the GP because there are also etiologies of tinnitus that can easily be fixed. Let's say like some earplug that can be removed, that will make sure that the tinnitus disappears instantly. But also the psychological components are often there. And in case there is some hearing loss that is causing the tinnitus, then we also want to know if that is present and if there maybe needs to be some extra treatment from the audiology part. So for diagnosis, I'm not a big fan of getting patients to come to me as a physiotherapist in first line. So I like them in second or third line most of the time. So, but for the somatic tinnitus specifically, there are actually tools that we can use to make that distinction between those patients who we might be able to help and those we can be sure about that we will not be able to help.
Okay. So usually all the patients that you see are referred to you by the GP, and
Most of the
GPs,
time, even by the ENTs, because my clinical work is in an ENT department, so it makes sense that they see the patients first. But they could be referred from the GP as well.
Okay, so they are excluding other sources
Indeed.
of tinnitus, and then they do make the diagnosis, or they do suspect that it's a somatosensory tinnitus, and then they refer out to you.
Yeah, indeed.
Okay, and can you maybe tell us how do they diagnose, or how do they reach a diagnosis of somatosensory tinnitus?
Well, what they usually do is, or they have a suspicion of somatosensory tinnitus, and it still needs to be confirmed, because some of the tests I am doing when patients come to me are not that easily done by people who are not trained as a physiotherapist. But most of the time, they get this suspicion when patients also have neck problems or jaw problems apart from their tinnitus. Yeah. And very specifically, if the patient already indicates that when the tinnitus is worse, then the neck pain or the jaw pain is worse as well, or vice versa. So that's actually a very good indication. And if the both pain and tinnitus complaints started in the same few days, that's also a very good indication.
Okay, again, very similar to cervicogenic headaches.
Absolutely.
Yeah. And okay, so a patient is referred to you, and you already touched upon that. How do you determine if this is a patient that you might be able to help or not?
I actually use a flowchart that we created a few years ago. It's published as well, so if you want to, you can find it. It was published, I think, last year, 2022. And it gives a nice overview of how you can identify patients that could benefit from physiotherapy treatment. And what I already told you, that's the first factor to look at. But I also look at tension in suboccipital muscles, in the jaw muscles. Of course, I will ask about if patients already noticed some similarities between changes in their tinnitus and changes in their pain complaints, because often patients actually know. So another thing that's often mentioned is that patients can actually momentarily change their tinnitus. And that means that when they're, for instance, clenching their teeth, then the tinnitus changes. Or when they do a certain movement, then their tinnitus gets louder or the sound changes. And that is a good criterion to use when you also have some other criteria present. But it's quite important to know that a lot of people have certain movements they can do that will change their tinnitus, also when it's not somatic. So I wouldn't use that as let's say a primary criterion. So, but it's always interesting if you have a lot of the criteria that are present and they can also change it so instantly. Then that's interesting to know as well.
Yeah, I agree. I think that's also something with other patients and other body parts. If you're able to modify symptoms, then it's usually, I don't know if it's described in research, but it's usually a good predictor that we can do something about a patient's symptoms or complaints. And for all the listeners out there, if you're wondering about studies that we mentioned during this podcast, we'll put all of them in the transcript of this podcast episode. So don't worry, we'll definitely put a link in there for the flowchart. And Sarah, are there any special tests? I mean, a lot of people know us from YouTube because of the special tests, although Physiotutors is way more than special testing. But any Michiel test or something that you came up with for the condition?
Not really, actually. We do have the what we called the RAST tool. So it's short for a rapid screening tool for somatosensory tinnitus, and that's something that I can help you with later to put with the podcast.
Yeah.
But no specific testing actually. What I basically do is looking at cervical spine movements, joint movements, jaw movements. I look at muscle function of the cervical spine. So it's actually a classical cervical spine investigation, classical or facial examination. Just looking at potential dysfunctions, because that's maybe an important thing. Also for diagnostics, if there's no dysfunction whatsoever to be found, then it's very unlikely you will be able to change a patient's tinnitus. So there needs to be some dysfunction, or we don't have anything we can work on in practice.
Yeah. And if we start with the cervical area, is there, I'm probably guessing it's upper cervical, the upper cervical spine that you're looking in particular?
I'm particularly interested in the upper cervical spine, but I also always look at the lower cervical spine, cervicothoracic junction, because, well, if there's something wrong in the upper cervical spine, then often cervicothoracic junction is also not entirely well most of the time. So I look at the patient as a whole, but I'm specifically interested in this upper cervical region indeed.
Yeah, and I'm guessing that's joint motion and pain provocation.
Joint motion, pain provocation. I'm looking at myofascial trigger points, but also muscle function. So deep neck flexor and extensor muscle testing is also something I always do.
Yeah. Any specific muscles that you're interested in?
Well, the deep neck flexor muscles we're always looking at, but also specifically the upper cervical extensor muscles. They are often very tense in patients with somatosensory tinnitus.
Okay, and if we look at the area of the jaw, what is your approach there?
There I'm also looking at mobility, so it's actually quite easy. You can ask a patient to open their mouth as wide as they can go, and then you just need a ruler to measure between the teeth how far they can go, and normally it should be around 40 millimeters. So if you notice that there's only like 20-25 millimeters, that's going to be a functional problem. So that is something I'm looking at, but also muscle tension in the masseter muscles, temporalis muscles, and of course also a broad anamnesis about functions, parafunctions like clenching, grinding the teeth. That's also part of the investigation.
Yeah. Okay, and we already said most people come via the GP or the specialist. Are there any red flags that we need to be aware of in case they haven't already been excluded by the specialist or by the GP that you'd be looking at?
Yeah, well, the most important red flags are the general red flags we look at in every patient that comes to us in first line. Because in very rare cases, tinnitus can be the symptom of, for instance, a brain tumor. Yeah. So that is very rare, but you don't want to miss those cases, of course. Yeah. So that's also why I'm not eager to get a patient with me who has never been seen by a GP or an ENT for tinnitus complaints. So that's one part. One red flag to look at. And then those patients who I also am not eager to start treatment or physiotherapy treatment are patients with, let's say, high symptoms of depression and anxiety, because that also often happens either as a cause of the tinnitus, so depression, primary depression, or anxiety symptoms can cause tinnitus, but also sometimes as a secondary complaint. So some people get tinnitus and then get very anxious about it. So, and well, in my experience, I noticed that even if they have symptoms of somatic tinnitus and we start treating them, they do not really react very well to treatment when these symptoms of anxiety and depression are very prominent.
Yeah.
So I often send them first to our psychologist, and then sometimes later on they come to me for as a second treatment, let's say.
Yeah. Okay, and moving on to treatment, how effective is physiotherapy treatment for tinnitus or for the somatosensory type of tinnitus?
Well, if the patient is very well selected, and that is actually the most important part, then the effectiveness of treatment goes up to 65%. We found in our latest study. So that's one published in around 2020, if I'm not mistaken. We're currently doing a new study where we still want to improve that efficiency rate. And it looks as if we are getting better and better at selecting our patients and at increasing this success rate. So.
Yeah, that sounds pretty promising. I don't think there's so many fields where we make 65% of the people better. Or I'm not sure if there's a lot of fields.
Yeah.
And what would be the course of a typical tinnitus patient? Like, how long does it take until they really improve?
Well, our treatments at this point lasts for about 9 to 10 weeks. So that's the most used approach currently. And we noticed that you actually need this period of time to get the changes in muscle function. Because in the first studies we did, we had a treatment period of 6 weeks.
Yeah.
And that worked well in the short term, but then we noticed that people were getting worse again after a few weeks. So that's not really what we wanted. So we extended the treatment period. And now about 9 to 10 weeks seems like a good period for the treatment. And you certainly don't need to see patients like 2-3 times a week. Once a week, and later on in the treatment, even once every 2 weeks, is perfect. So the most important part is actually that they are doing exercises on a daily basis and that their muscle strength and coordination of neck and jaw muscles is improving. And therefore, they need this period of time. Like, you are not training for a marathon in 3 weeks. You're not treating tinnitus in 6 weeks either. So,
And in your studies, do you see that the improvement of those patients is also related to improvements in muscle function? Because sometimes in studies you can see that, for example, I'm thinking about patellofemoral syndrome. Sometimes you see you train muscle function. The muscle function doesn't improve, but patients do improve.
That's a very interesting question, because on an individual basis, we actually see that the dysfunction that is present improves. But on a broader scale, we were never able to get this average improvement. And that's actually because the type of dysfunction differs largely between patients. So one patient will have a mobility problem, another patient will have like a deep neck flexor coordination problem, another one will have other issues. So the type of dysfunction is so heterogeneous that on average in a study population, it's very hard to prove that improving the neck function will also improve the tinnitus. But when you look at an individual basis, then we indeed see that in those patients with, let's say, a mobility problem, when we increase mobility, then their tinnitus starts to change after a while.
Okay. And in your studies, do you see that patients do get tinnitus again after a while?
Well, sometimes that happens indeed. And most of the time that's because their neck or jaw problem gets worse again as well.
Yeah.
So that's actually something we saw in the first study, very typically. So I told you our treatment there was actually too short. And after ending the treatment, so after the follow-up, we saw that tinnitus was getting worse again, but also the neck complaints were getting worse again. So,
and how much of a follow-up are we talking about then?
In that study, we had a 6-week follow-up, but we did later on studies where we had a 3-month follow-up as well.
Okay.
So,
so if they don't keep doing the exercises, it's probably going to deteriorate after about 3 months, or that is
indeed.
what we know at least.
Yeah, and patients I've been following up as a clinician in practice, I noticed that in some patients it takes 6 months, in others it takes a year, 2 years, 3 years. It largely depends on how good their neck stays or their jaw problems have been solved, and also sometimes linked to stress. Some people get neck problems in a stressy period, and then their tinnitus will appear again as well.
Yeah. And do we have any studies about prognostic factors? Do we know, because you already mentioned people where psychosocial factors are present, they probably have a worse prognosis.
Mm-hmm.
Do we have more studies about positive and negative prognostic factors?
We have 2 studies on positive prognostic factors, and it's actually combined with negative as well. And what we saw there, it's 2 different studies we did in our clinic, and of course we hoped they would show the same, but they didn't, as it always goes in scientific research. And from the first study, we know that when tinnitus and neck complaints increase and decrease simultaneously, then patients are more likely to benefit from the treatment. Also, when there are certain postures that increase the tinnitus loudness, and in case a patient has a low frequency tinnitus, which means a sound of 1000 hertz or lower. So it's more like a low humming sound instead of a high beeping sound, for instance.
Oh, okay, that's more based on the description by the patient, or can you actually measure that?
No, you can actually measure the tinnitus frequency. So, and that's done by the audiologists. And what they do is they present certain sounds to the patients, and then the patient has to tell them which sound resembles their tinnitus the most. And that's the way they try to measure the frequency, and in the same way they can measure in a more objective way the loudness of the tinnitus.
Oh, okay, interesting. And we already said we're looking for dysfunctions. So a patient is referred to you, the GP suspects that it's somatosensory. Your assessment is probably going to focus on, okay, which dysfunctions are present in the neck, in the jaw area, and your treatment is probably going to last 10 weeks. Can you talk to us about how a treatment of yours would actually look like in practice? How would you start with such a patient?
Well, I always start from the dysfunction that is present in this patient. So often there will be a combination of cervical spine mobility problems, some muscles will need stretching, others will need strengthening. So I will make an individualized program based on the dysfunctions I found. And then we start at the point where the patient gets cervical spine mobilizations, where they get exercises in the clinic once a week, and they will get a home exercise program as well.
Yeah, and they're doing those exercises like every other day, or how many times
on a daily
recommend
basis.
it?
So they really need to do them every day. But I try to keep my programs not too long. So most of the time they have like somewhere between 3 and 6 exercises. So that will take them like 15 to 20 minutes a day, because, well, we all know that if you give them a program for 3 hours, they will never do it on a daily basis. So
yeah, I fully agree. Personally, I have like this 3 exercise rule, because I know I usually give more exercises than 3. Then people probably don't do it, but depending on the person. But that's my own 3 exercise rule.
Yeah, absolutely. Well, 3 is a little bit a problem when they have both neck and jaw problems. Then that might be a little bit too strict, I think. But if it's only neck related, I also stick to the 3.
Yeah, I can see that. Okay, we're slowly coming towards the end of my list, but I have like 1 or 2 questions left. Do you also see that you make people at least temporarily worse with exercises? Do they, through exercise or manual therapy, do people have extra complaints, or does it get worse?
Well, sometimes that happens indeed. Often not because of the exercises. If patients tell me that in the course of a week when doing their exercises, their tinnitus got worse, then most of the time they haven't done their exercises correctly. So that's an indication for me to go and check and see what they've been doing. But with the manual therapy, that sometimes happens indeed when you're a little bit too enthusiastic as a therapist and go in a bit heavily. Then tinnitus might get worse. And that's also one of the reasons why I never use upper cervical spine manipulations in patients with tinnitus, because that often increases their tinnitus, at least for a couple of days. And it's actually really important to tell patients with tinnitus that might happen, because, well, in pain patients, patients often expect something like that to happen, but tinnitus patients are not that keen on getting an increase of their tinnitus. And when that happens and you haven't warned them, they might not come back after your first treatment. So it's really important to notify that something like that might happen.
Yeah, I can imagine. Like I've luckily, knock on wood, I've never experienced tinnitus, but I can imagine that it's a really annoying and really impairing complaint to have.
Yes, absolutely, and especially when it's very recent, then it's really tiring as well for patients, because it's a sound that's constantly processed in your brain. So you get really tired because of tinnitus.
Okay, and now we talked a lot about the topic. Now I want to know personally, but also as a young physio, maybe how can I gain more knowledge on tinnitus? Because I think it's a field that, like, at least I was hardly aware of that we can do anything about it, and I'm probably not alone, which is unfortunate. So how can I learn more about tinnitus and physiotherapy treatment of tinnitus?
So there are quite a few courses on tinnitus and somatic tinnitus. I'm personally giving courses in Belgium, the Netherlands, and in Spain. So for now, so there are quite some courses, and it goes from like 3 hours in a larger course on tinnitus complaints to like a whole day about physiotherapy. and somatic tinnitus. So there is quite some choice there. So depending on what you need.
Okay, and do I need to be a manual therapist or have prior knowledge of the temporomandibular area? Because like I know quite a bit about the neck, but not so much about the jaw.
Well, it's always a plus if you also have some basic knowledge. And as a manual therapist, most of us got some basics about the jaw as well. And I think you don't really need to be a real orofacial physiotherapist to start somatic tinnitus treatment. But it's always good to know your own limits. And when you're looking at a patient and you see like, okay, this is beyond what I can do, then there's always a possibility to refer them. But knowledge about manual therapy is something that I think is quite important, especially because it's often located, or dysfunctions are often located in the upper cervical spine. I think it's a serious plus if you have a manual therapy background.
Yeah, I can see that. Hey, and Sarah, looking at my list of questions, I'm done with my list. So is there anything that we haven't touched on yet that you would like to add?
Maybe because I forgot to tell you when we were talking about expectations after treatment. Maybe it's important to also add what you can expect as a patient and as a therapist from the treatment, because most of the time tinnitus will decrease. So tinnitus will go less loud, will go less intrusive, and patients will be very happy with that. But it's very rare that tinnitus actually disappears completely.
Okay.
So that's quite important to know. So that you don't go and tell your patients, I will cure your tinnitus, you won't hear it anymore. So most of the time, patients will still be able to hear their tinnitus when they're in a quiet room, for example, but it will not be that prominent on a daily basis, day in, day out. So that's what we can do as physiotherapists.
Okay. Hey, and totally unrelated side question again. Wasn't it Vincent van Gogh who also had tinnitus and who cut off his ear because of the tinnitus?
Well,
isn't that the story?
That's indeed a story. I don't know if it's true, but it might be true indeed.
Yeah, so maybe you could have saved his ear had he had any access to tinnitus physio.
Who knows?
Yeah. Okay, at last, Sarah, where can people find you if they want to reach out or if they want to learn more about tinnitus or attend one of your courses?
Well, I'm on the University of Hasselt website, and they can also reach me via my email address at the Antwerp University Hospital, which is basically my surname at uza.be. So.
Okay, yeah, we will definitely put the links in the transcript again. Okay, with this being said, Sarah, thank you so much for your time and knowledge. It was a pleasure to have you, and also thanks a lot for listening to this episode, to all the listeners out there. And as already mentioned, to access the transcript and additional resources, make sure to sign up for free Physiotutors membership on physiotutors.com and benefit from more useful physio content. And as always, if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts, and consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll see you in the next podcast episode. Bye.